we are the organizer of this epilepsy surgery webinar. This is on behalf of ILAE Asia Oceania and as a co-chair of its epilepsy surgery task force. First of all, I would like to express gratitude to Professor Chandra and Manjari Tripathi for their devoting effort to keep this webinar series going. And this is the fourth time. Today's topic is the tumor-associated epilepsy, surgical management of tumor-associated epilepsy. And I very hope that this webinar will contribute the development of your knowledge and establishment of epilepsy surgery program in most of your countries. And first of all, I'd like to have some words from ILAE. The president today, John is here. John is absent tonight. Then the former president.
John is here.
John is there. Yeah.
John is here.
John is here. Okay.
Yeah.
So, Professor John Down, could you give us?
Yes. Well, thank you, Kensuke.
Your words.
Well, all I can say is that I'm very grateful that our region has Sarat Chandra and Kensuke Kawai leading the Epilepsy Surgery Task Force, because we know that many patients with epilepsy are best served by surgery, and increasing our knowledge and capabilities in the region are critically important. So I'm very grateful for not only their leadership, but friendship and the initiatives that they're convening. And this fourth session, like the others, I'm sure you're going to find very interesting, with the help of excellent team of experts, not only from India with Manjari, but internationally. And we're very grateful for your time to join us, because even though we're so far apart in this crazy world at the moment, I'm pretty confident that we can still achieve so much if we face the challenges together. So I hope you enjoy this important educational initiative. Thank you.
Thank you, John. And Professor Ikeda, as a former president of ILAE-AL, can I have your words, Professor Ikeda?
Yes, thank you very much, Dr. Kawai. I'm Akio Ikeda from Kyoto, Japan. I'm a past chair of the ILAE Asia and Oceania until that last September as a chair. It is my great honor. I just echo that the words of the John. This is really the important and excellent opportunity for all of us in belonging to the ILAE Asia and Oceania to learn how to manage and then decide at the very difficult cases. And it is very fortunate for us to have that the excellent guest faculty today, Professor Christopher Skidmore, and then the Dr. Christopher Miller. So we are looking forward very much to having the fruitful discussion. Thank you very much. In spite of the difficult time, it is the more early in the morning, or it is not so early, but I think I really appreciate both of you for joining us. Thank you very much.
Okay, thank you, Akio. Okay, now we'll start the webinar. And first, Professor Manjari Tripathi will present a case. She's a professor of neurology at All India Institute of Medical Sciences and in charge of MEG resource facility. She's a well-known epileptologist. Okay, Manjari, please start.
Thank you. It's really nice to see all of us back again on this session. Today's topic is lesional tumoral seizure generator resulting in drug-resistant epilepsy. So I actually have two cases, but I'll start with the more difficult case. And, because the usual lesional single tumor would, not generate so much of discussion. So here's a young man, and he spent, he's about 28 years of age, really young, and dropped out from his, usual schooling and his usual, he should have been in college and having a job right now. So he's just got left behind and all that. And he came to us right in 2018, where he'd been, having seizures for 15 years. So really, these seizures had just gone on and on despite a trial of several medications. And you can see that 13 years, just as he got to his teens, they started. And that's really a difficult age to even, adjust to anything normally, also physiologically. But then on top of that, to have these seizures come unexpectedly really took a toll on him and his family. His frequency was not too much. It was just about 1 or 2 a month. Usually in India, we are used to seeing several over a day. So he was having about 1 or 2 episodes a month. He had never had seizures in his childhood, no febrile seizures. There wasn't any history of meningitis or encephalitis in his childhood. There was no history of head injury. However, because of these seizures, which were very often, generalized, so these seizures caused him to fall down. And he had, had several falls during these seizures, among which in one of them, at the age of around 15, he had fallen from a flight of stairs. And this had led to a prolonged concussion. And he had been hospitalized. However, his CT was done at that point of time. We didn't have any of those reports available to us when he came to us in 2018. So this was all the history he had. And if you went into the seizure history, the parents said that his first episode occurred when he was all alone. And it sounded kind of generalized because they found him in a mess where there was he had passed urine, and there was a lot of frothing from the mouth, and there was a tongue bite. So we presumed that the first episode was a generalized episode at the age of 13 years. But later on, the parents started him on phenobarbital, and he started having episodes where they noticed blinking of eyes and posturing of both upper limbs. They were not able to tell or discern whether it was any particular side first, or the right or the left, or whether the eyes went to any particular side. So as is common, many a times there's so much of activity when the seizure happens, and people are very anxious that they fail to notice any lateralization. There was another seizure kind in which they would say he would make a loud noise and sometimes just be silent, and then his head would turn to one side. But however, they were unable to relate which particular side. Again, if the mom would say right, the father would say left. So there was no, kind of chronorhythmicity to these seizures. They weren't occurring in the night. They were occurring at any point of time of the day, whether he was just sitting in bed or whether he was just sitting for having his breakfast, food, or dinner. So basically, there was no nocturnal preponderance of these episodes. So with this kind of history, we were really, at least history-wise, all we knew that he had drug-resistant epilepsy, and he was having generalized episodes. The episodes were not particularly happening in sleep. There was no nocturnal chronorhythmicity. And they were pretty much getting generalized very fast. So we were kind of certain that definitely this is something which is probably lateralized, because the parents did give us a history of head turning, but it's getting a very rapid secondarily bilateral tonic-clonic component to it. And so definitely mesial temporal onsets were out. We were not very certain about any kind of aura, because he did not tell us any aura. There was no visual aura, there was no experiential aura, there was no auditory aura, there was no olfactory aura. So and somatosense. So because he had no premonition or no feeling before the seizure, we were really not able to discern which particular lobe. But because of the rapid secondary generalization, one of the possibilities we kept was whether it was definitely not mesial temporal. It could be neocortical, or it could be frontal, or it could be occipital, which is going rapidly. But there was nothing else to help us, at least in history. So with this, we proceeded to evaluate him in our epilepsy monitoring unit. Before that, he had received, and he was at the time of evaluation on 3 major anticonvulsant drugs, clobazam 40 and levetiracetam 3 gram, and carbamazepine. And of course, he had no focal deficits or no neurocutaneous markers. He had a neuropsychological input from our colleague, Dr. Ashima, who's a psychologist, and he clearly seemed to have an impaired right hemispheric, particularly temporal visual memory. Both immediate and delayed were impaired, and visuoconstructive was impaired as compared to intact verbal memories, which were, so that gave us some clue that, before we put him into the monitoring unit, that maybe there's something on the right hemisphere if nothing could be obtained from history and aura, absence of auras. So we had a hypothesis that we are dealing with something from the non-dominant hemisphere. So we had recorded around 3 events, all of them very stereotyped in the monitoring unit. And as you can see here, so subsequent episodes are also very similar. So when we look at these episodes, clearly in the initial part, he had some kind of an arrest where he was not responding to the staff's commands of lifting his hands, telling his name, showing his tongue, asking what he's experiencing. There was no response. And then he has a little bit of movement of the right lower limb where he just moves his right lower limb. It's not clonic. He just moves it as to say he's having some kind of semi-purposive activity with his right lower limb. And then he has suddenly a turn of his head to the left, which is quite forced. And this is followed by a very rapid generalization in which we see in the initial part that his left upper limb is extended. And this is followed by a flexion of the right upper limb with few clonic movements of the right upper limb. And then he is into the full-blown secondary bilateral tonic-clonic movements. And he terminates the seizure with a clonic jerk, and the clonic jerk is on the right upper limb predominantly and the lower limb to a certain extent. The second event is also very similar. Dr. Chris Kedmore, any more observations to the description?
No, I think it's a wonderful description and a great video illustrating several lateralizing and localizing signs. I assume the individual is right-handed.
Yes, he's a right-handed individual.
Yeah, so I agree that the neuropsychology was suggesting the right hemisphere, and then the head movement I would actually classify as version.
Yeah.
So there's a left versive movement, which would suggest right hemisphere onset. And then the left arm tonic, I wasn't 100% convinced that it truly got to what's called the sign of 4, the number 4, but that left arm tonic is also suggestive of right hemisphere. And then the last clonic jerk being on the right side is also suggestive of right hemisphere onset. That's an ipsilateral sign. So you have 3 semiologic features all pointing to right hemisphere onset.
Okay. Yeah. So we also had the similar information gathered from the semiology, and so let's look at his interictal EEGs. The interictals show a broad kind of sharp spike, which is seen almost all over the right hemisphere, with some kind of suggestion of a reversal around T6, but not very certain about it. And this is one more interictal. There were 2 interictals. There was another one which is missing here. So and then as we go on to the event, and this is a pruned event, and we can see here towards the end of the epoch, there seems to be, again, the similar kind of activity which we had found, starting first in the last second, starting first on the right hemisphere with a sharpish component around T6 and also around T4. So that's just seen in the last millisecond of the epoch, and then it kind of vanishes. And here we see the onsets. Of course, they are kind of masked with all this muscle interposed, but there seems to be a large amplitude slow seen around T4, and it progresses like this, converts into a faster rhythm. It does reflect to a certain extent on a slower format on the left side, and then he's kind of generalized. So really, this is where he's generalized, and this is the postictal. Postictal shows a little larger amplitude slowing on the left and lesser on the right. Another event where we see the T1 electrodes over here showing some delta creeping in at F7, and then it evolves like this. It's also well seen on the right temporal chain, and then evolves further. And you can see here the right temporal definitely shows much better progression. So I was not very certain of this slow over here, but there is some reversal at T2. So the onset page here, I was not very certain, but then when you go to the next epoch, you clearly see the larger amplitude and the better rhythm evolving around T2, which is the right anterior temporal, and you can see it much clearly on the third epoch. So this was, again, my impression was the right, though the onset was not very clear. Another event, this is his third event, which shows a similar kind of delta come in with higher amplitude on the right, seen on the left, but of lower amplitude, and then it evolves like this. So based on the ictal onsets, I tend to err on the right temporal onsets based on these rhythms which I saw. Chris, what are your comments on the EEG?
Yeah, no, I agree with the interpretation. I think that delta onset in temporal lobe epilepsy has been more commonly associated with neocortical onset epilepsy as opposed to mesial, and so we have both the semiologic features as well as now the EEG really pointing more towards a neocortical onset. The spike at T6 worries me a little bit because it's kind of getting outside the margins of a typical temporal resection when we're starting to think about epilepsy surgery. But I do think that there's a good amount of data now pointing towards electrographically that right hemisphere as well.
Okay, thank you, Chris. Dr. Dunn and Dr. Ikeda?
Look, I can only agree with you and Chris. The key issue here is that semiologically and electrographically, we're pretty comfortable this is a right hemispheric onset. However, the actual localization is fairly uncertain. As we all know, surface discharges, even if they emerge in the anterior temporal region, may have come from somewhere else, and whether it be temporal neocortex or inferior frontal or even more posterior. But either way, he's got focal epilepsy, right hemispheric.
Yeah. So we then...
May I say?
Yeah, Dr. Ikeda, yeah.
Yes, I essentially agree all of these kind of opinion. Speaking of that, the semiology, I'm very much impressed by that the initial head version and also the asymmetric tonic posturing involving that the bilateral upper extremity and also lower extremity also shows that the abduction and then the knee flexion in the asymmetry. So I think it's most likely that the figure 4 happens, and also it also shows some sort of the head version to the left, but at the same time, asymmetric posturing involving that the right extreme, the upper extremity and lower extremity may involve to some extent that the frontal area as the spreading patterns, because that the whole seizures looks like mostly that the tonic component initially. So although it's come from that the temporal, but it can spread to that the deeper area, the basal ganglia, but at the same time it can spread to that the frontal, making that the further more that the asymmetric tonic components even from that the beginning of the seizure. That's what I feel. So therefore, the EEG finding is the very consistent as the initial delta or the T6 or T2 spike activity, but the later it also shows that the frontal activity. That's what I feel at this moment. Thank you.
Yes, that's a good pickup, Dr. Ikeda, because this patient wasn't so simple as, and I really appreciate, I really admire you for your frontal pickups. It's definitely going frontally later on, and we shall see that. So, yeah. So just to...
Manjari,
yeah.
Can I make a question?
Yes,
so
yes.
You said the family said that he makes a sound during seizure. Is that just a sound, gagging or something?
Yeah.
So is there any no vocalization or verbalization? No.
No, he doesn't verbalize. He just makes or it's just like a loud vocalization. It's not a verbalization. There's no decipherable language which he has during the seizure.
Okay. If so, that will help the information. So, okay. Thank you.
So just for the students here who've joined us, well, in the beginning of the seizure, he had a kind of arrest where he wasn't moving around much, and there wasn't a wide and palpable fissure in him. He was just having, this just would suggest that there's some part of the hippocampal circuit which is involved. There were some right lower limb automatisms which I thought were definitely there, because his right lower limb was moving, as if to say he's kind of shaking off something in the bed. And these were pretty stereotyped across all his events. And they were in the right lower limb. And then he has this version, which is a forced turning of the head. And we know that this would involve, spreading to the supplementary SSMA as well as, the frontal eye fields, though he did not have a gyratory component to his seizures. So that could explain a frontal spread. And then he definitely had a symmetric, I felt he had a symmetric tonic posturing, which is with a figure of 4 with extension of the left upper limb, which is defined as sustained muscle contraction of greater than 3 seconds. And this would again indicate an activation of the SSMA contralateral to the side of the extended hand, which would, in his case, was the left upper limb, so it would again go to the right. So he did have a last clonic jerk in the right upper limb as well as the right lower limb, and this would just suggest that it is ipsilateral, which is the right hemisphere, and the mechanism suggested for that is a metabolic or ischemic exhaustion and a post-ictal depression. So this was an explanation for his semiology, at the end of which we thought that it's probably right-sided, and if we have to take a guess, it would be neocortical temporal with a very rapid spread to the frontal cortex is what we thought. However, this is his MRI, and I'll just run through the various sequences and see if anybody can pick up anything. Do ask me to halt or repeat to show you these sequences. So the occipital lobes were normal. Any comments on the lesion seen here?
So there appears to be several
Lesion
frontal,
seen
one
here.
gyrus rectus.
Yeah,
Was the gyrus rectus one considered to be, yeah, that one there?
yeah,
And then higher up on the superior frontal gyrus at the top of the convexity, a couple slices back.
yeah.
Looks
yeah.
like encephalomalacia with surrounding gliosis. And then I couldn't
Anything
tell
else?
if the hippocampus.
Okay, so we go to the hippocampus.
So, Chris, are you saying hippocampus just because the topic of today's lecture is on temporal lobe?
No, I wasn't convinced if the hippocampus on the right might have looked slightly brighter. And, you know, the duration of epilepsy is long enough. and
Okay,
started
so
early
here
enough
it
that
does,
you could have
in
dual
this
lesion.
section, it does look a little, a little brighter.
But then there also looked like there was an area of encephalomalacia with surrounding gliosis. He was either in the superior temporal or middle temporal
Okay,
gyrus.
so we
You go
go
back
to
a couple
that.
slices.
So middle temporal gyrus, we're coming to
Yeah,
it.
right there.
Okay. There's something there.
It looks like it's got some cystic structures to it too as well.
Yep. Yep. So we can see it in the other sections. So here it is. So there's something here again. Chris, any comments on this? Dr. Akida, Dr. John Dunn, on this lesion in the middle of the middle temporal gyrus.
And even Chris Miller, you can give your comments here.
I think the only other thing I noticed, if you go back to the coronal flare image, there was a, in the superior frontal flare hyperintensity, it looked a little like a transmantle sign to me, which can occasionally be a sign of focal cortical dysplasia. If you come, yeah, right, yeah, you see there's a little bit of a streak coming down from that intensity down towards the ventricle. Yeah, exactly.
Okay.
May I say? I'm very impressed by that the ICTA EEG. Manjari showed that the 3 independent ICTA EEG, but the I don't think that all of them show that it's similar ictal onset patterns. Some of them shows that some interictal spike at the T6 and T4 shows some a little bit ambiguous pattern, but the another one shows that the quite large high amplitude delta. And then the third one shows that the quite fast activity at the left frontal. So I just wondering that since that the patient have at least a 3 foci at the right superior frontal and also the right middle temporal and also the right rectal gyrus. So 3 of them may be each independently seizure focused, but that's it's one possibility. But I still wondering that what's caused this kind of 3 independent lesion. It is caused by some trauma by means of some repeated head injury for some reasons. But I'm very curious about that the different pattern of the ictal EG.
Yeah, and I agree with Dr. Ikeda. I think that, one of the questions becomes, do you have an older MRI scan before that fall down the stairs, right? Because he's had numerous head traumas. And so the frontal lobe lesions do kind of look like that counter-coup injury that we can see after traumatic brain injury. And so the question is, did the middle temporal gyrus lesion come first, and that's the cause of the epilepsy? And what we're seeing in the frontal lobe is merely a result of the injury from seizures, or now, given that how long his epilepsy has been, is he multifocal epilepsy?
So we do not have any imaging of his. He came with his own personal MRI, which again actually showed us only the frontal lesion. It didn't pick up the temporal lesion. The temporal lesion got picked up in the MRI done with us. So he came in as traumatic frontal encephalomalacia to us. And there, as I told you, he had fallen several times due to his seizures, which used to generalize almost every time. And on one such occasion, he had fallen off quite a deep flight of stairs and had been in altered sensorium, had to be admitted. So we do not have his baseline imaging where we could have probably seen his brain without, and we speculate that what we saw in the frontal lobe is a result of that trauma which he had, and he needed admission for his altered sensorium. So definitely what we found was there were 3 lesions. One was in the middle of the middle temporal lobe. The other was, of course, superior frontal, and the next was a basifrontal gyrus rectus kind of lesion. So while he was...
So Manjari, could you show the middle temporal gyrus and kind of zoom it? Because, yeah, is it possible for you to zoom this? I just wanted it to make it clear for the viewers.
So the lesion which is seen here is not too large, but it is the convexity is maintained and kind of in one of the sections on FLAIR, it seemed to have a cystic component also. So for this lesion, our radiologist felt that this is a DNET, small DNET. I do not know if there's any varying opinion.
Dr. Kawai, any opinion from you?
Dr. Ikeda, Dr. Dunn, Dr. Chris.
Dr. Kawai, muted. Dr. Kawai, muted.
Oh yeah, yeah. I agree. This is like one. The against thing is there is a kind of in case of DNET, you usually do not see this kind of coloring structure. So I wonder, is this really DNET? I don't know, the cystic. So it may be ganglioma or other tumors. I'm not sure.
May I say?
Yes, yes.
Yeah, I totally agree that among the 3 regions, that the feature of the 3 regions is a little bit different. I totally agree that the right middle temporal gyrus, which is a cystic, it may have some sort of a calcification, but we need to see that the CT to see that the calcification is present or not. Speaking of that, the right superior frontal lesion is actually the structure abnormality, including that the cortices and also white matter. So it's most likely some sort of traumatic or whatsoever, but it is totally different from the DNET. And also rectal gyrus lesion is also. The patient may have a different etiology of lesion, but I don't know how developed that the intractable seizure, presumably from one's focus or two foci. Yeah, thank you very much.
One thing, if I could add, I mean, I think we don't necessarily know what these lesions are, but they're all on the surface and they should all be surgically accessible if we can try to figure out which one we think is the seizure generator or most likely to be epileptogenic.
So we had the opportunity for getting an Epilepsy, which was injected at 28 seconds of his event, and that picked up basifrontal and ipsilateral thalamic hotspot. And this is the syscos. He also had a PET, which showed, of course, the frontal lobe just showed the hypometabolic area, but the right temporal also looked hypometabolic. He had MEGs. We do a 3-hour MEG, document as many interictals. It showed a dipole. In the MEG, the right is the right, unlike the MRI and the SPECT and the PET. So it showed dipole bang on concordant with where his cortical lesion was, as you can see here. And it also showed, the modeling also showed activation in the right hippocampi. However, there was nothing picked up in the frontal lobes during the MEG. So with this, we were certain that he has onsets in the right hemisphere. At least I personally thought it was more of temporal onsets spreading very rapidly to the frontal, which could explain his very forced version, as well as his figure of 4, as well as the ictal discharges which follow on in the frontal area after onsets in the T1, and the ictal spect which picked up the syscos which picked up the frontal hotspot. However, my hypothesis was that the onsets are still temporal. However, we could not rule out just a frontal or co-activation of both areas. And our hypothesis was that if there's a lesion seen, definitely we see a lesion. We just don't see one lesion, we actually see 3 areas which are involved. So one would like to document the temporal domains or the temporal sequences of involvement of these areas. And with this, we'd like to implant him with SEEG electrodes. However, since for us, SEEG is an out-of-pocket expenditure and proves to be pretty expensive for the patient, we have to limit our electrodes. We do not have the luxury of putting in too many electrodes. So while kind of economizing on these, during our pre-surgical discussions, we thought we'd put in one at least anterior to the lesion, one in the hippocampus on the right, and one in the basifrontal, sampling basifrontal, as well as the dorsolateral frontal region. So totally have in 4 SEEG electrodes and sample these areas and then stimulate these areas to see from where he's having his typical seizures.
So Manjari, before you proceed, I would like to ask all the faculty here, especially the surgeons, Ashwini and Kensuke, with this extensive pre-operative investigations, would you be confident to go ahead and do a direct surgical excision, or would you still go in for a SEEG in your center?
I think in our center, we would still do a stereo EEG. There is the ictal EEG had some doubt. I mean, the interictal EEG still had some doubt. on whether the localization is absolutely temporal. I think ictal, it looked like it was going temporal, so it is involved. And with the versive head movements, there are two things that actually give you significant doubt that there could still be a frontal focus. So I think I'd want to explore in every scenario the frontal as well as the temporal. I know you said this, Manjari, that you chose maybe 4 electrodes or 5. I think I would also put one posterior to this lesion. It is non-dominant temporal lobe, and there was some suggestion that at T6 there could have been some delta activity. And in a non-dominant patient, you have the ability to do a little bit more generous temporal lobe surgery. So that's the only other strategy that I think I would add.
Yeah, I quite agree with Dr. Shara. So there are so many atypical aspects, and so we need some more examinations. But one extreme option is if I talk with family, patient and family, because this is the right side, and this may be a tumor, even if it is a long history. The resection of a temporal tumor without the further examination might be one option. So I will present both the options, and of course, as a epilepsy surgery, the former one is ideal, but I will discuss with family, patients and families.
I also agree with Dr. Kawai. I think it's actually very reasonable to, if you don't have the ability to do stereo EEG monitoring, to do a very more intellectual, I will call that, resection. I think it's very reasonable to even go after 1 or 2 of these lesions. Even the suprafrontal lesion is easily accessible, and the probability of that causing deficit is going to be very low. And the only one that's doubtful is maybe the inferior frontal in the gyrus rectus, which is a little bit harder to access. But even to do a lesionectomy surgery without necessarily knowing the exact extent of the epileptogenic network, I think is a simple first operation. And you can also use stereo for the implant in case it fails.
Dr. Dunn?
Oh, look, it's I can only agree with what other people have said. As Kenzuki has mentioned, one of the things about that temporal lesion is that we're assuming that it's a DNET or another benign lesion, but even such lesions, we can have doubts until the histology is available. And the other thing that's really worries me, and I've recently had this experience at home, is that a patient of mine with epilepsy and a DNET, proven histologically, at the time that she had surgery, which was over 20 years ago, the DNET wasn't completely removed because it extended into the ventricle. And again, we've had the histology reviewed by multiple centers, and it was a DNET. And then she presented with a asymptomatic until she had a hemorrhage into it with a malignant transformation. And so even DNETs, after long-term follow-up, can transform. And so the only thing for these lesions is to remove them, to know what you're dealing with, and hopefully totally remove them.
Thank you. Shall we proceed?
Ravi, can I ask your opinion of Dr. Ikeda also?
Nothing particular. I totally agree, all of them. Thank you very much.
So we implanted him with 4 SEEG electrodes, and he had similar events to the baseline, but he didn't generalize because we did not taper his medication this time. We just documented the briefer events, and he just has an arrest and does not respond. That was a very brief event, and then he has another. So he had several brief events during the SEEG monitoring without tapering his medication. is responsive now. And then he has, this is the next event where he is just lying. He has uprolling of eyes, and then his head, little oval movements, and then his head goes slightly to the right, unresponsive. So basically, the SEEG documented the events without his secondary generalized component. This was the frontal basal, frontal polar going to the dorsolateral frontal, anterior to the DNet, ADNet, and hippocampal. And we could see the onsets characterized by low voltage, high frequency activity, which is seen around almost all of the connections which are contacts which are in the anterior to the DNet SEEG electrode, as well as the hippocampal electrodes, followed much later by the dorsolateral frontal showing slower, sharpish waveform. So pretty much consistent ictal onsets. The frontal didn't show the onset. It was mostly anterior and hippocampal. Again, another event. So we could document several such events, and stimulation of almost all of these electrodes produce the habitual seizures, as well as stimulation of all these electrodes produce the habitual seizures. None of the frontal electrodes stimulation produce the habitual behavioral arrest followed by generalization. So none of the frontal electrodes showed any activity. So with this, we were more or less certain that it was probably onsets were in the DNet, and then there was a spread involving frontal circuits later. And he underwent, I think Dr. Chandra could talk about the surgery.
So this patient was operated almost a decade before.
And not a decade. He was operated in 2019.
2019, yeah. I'm sorry, I got confused with that. So in this case, we had a lot of discussion. So we were initially we were thinking of only excising the lesion, but then his visual memory was already impaired. And then we found that stimulation of, even the most of the stimulation of the lateral hippocampal electrodes produce seizures. But I think in one of the leads, even the medial hippocampal seizures also produced habitual seizures. And in view of long-standing etiology, we were initially bit either this way or that way. And finally, we decided to do a lesionectomy along with the anterior temporal lobe resection and the excision of hippocampus as well as amygdala also. We could have, now retrospectively, I think we could have just done a lesionectomy, but we did excision of both the lesion as well as amygdala and hippocampus. So the histology was both DNet along with...
No, it wasn't a DNet. They reported it as a cortical dysplasia.
Yes.
I do not know. We did go back and discuss with them, but the neuropathologists were very certain about the cortical dysplasia, and they also said there is a certain amount of hippocampal sclerosis along with it. So that was the histopathology. Yeah.
So over here, our question is, would you have done just a lesion excision, or would you have also gone in and done an excision of amygdala and hippocampus also? So again, this is open for discussion. So we could have opinion of all the faculty. So starting with the surgeons. So perhaps Ash could speak first, and then we could go to...
This is a non-dominant temporal lobe, and this patient had deficits. So I think it's very reasonable. If the EEG, the stereo EEG was suggesting any mesial involvement, I think we would have been quite liberal in considering, like you did, more than lesionectomy plus lobectomy. The probability of memory and functional deficits for the non-dominant temporal lobe in an epileptogenically lateralized patient is very low.
Kensuke?
Yes. I think Sarah, your choice is reasonable, and I myself do the regional resection of lesion, and then do the intraoperative the echo recording from parahippocampal gyrus using the subdural electrodes intraoperatively. And I know this is controversial, but practically we usually do that. And if we detect very active discharge from hippocampus parahippocampal gyrus after the resection of lesion, then we will add the hippocampus.
Thank you.
Okay. Mm-hmm.
Any other comments from others? Chris?
Yeah, so I think it's interesting, so DNETs histologically are pretty close to being cortical dysplasias and are often associated with cortical dysplasias just beyond the visible lesion that you can see. So I think, this is a classic description of dual pathology where you have hippocampal sclerosis plus, in this case, a cortical dysplasia or a tumor. And most of the literature would support your decision that, the larger resections, the patients tend to have better functional outcomes and better chances of seizure freedom. So I favor doing the larger resection, especially here in somebody, it's a non-dominant temporal lobe with, signs on the neuropsychological test, and there's already a deficit. So I think that's the right decision.
Dr. Dunn, Dr. Ikeda?
I agree with Ash and Chris. If, as we all know, we're used to seeing patients who have very obvious mesial temporal sclerosis who also have anterior temporal pole dysplasia, and limiting, in particularly the morbidity in a non-dominant temporal resection, if you like, a standard resection, anterior temporal pole and mesial temporal structures is low, and trying to finesse resections runs the risks of failed surgery. This is, if you like, a similar situation where we have an abnormal neocortex and a very suspect mesial temporal structures based on the solid evidence of the stereo EEG. So like Ash and Chris and you, I would have done the more generous resection.
So I just have a question. I don't know if I'm just with all the surgeons here. This is a small lesion and it's like cortically situated, very superficial. Could we consider even a radiofrequency ablation in such cases, or it's has to be a surgical removal?
So maybe Ash could answer that. He has a lot of experience with that.
We actually don't have so much experience with radiofrequency ablation. We have more with the laser ablation. The laser ablation has a larger field. You can do about 1.6 centimeters or 16 millimeters. So for a lesion this size, it could be ablatable, as long as the understanding is that you're not necessarily getting lesion plus. So you can probably remove this entire lesion with the laser ablation. I think that's accurate. I think with radiofrequency, if somebody has more experience, please correct me, but that lesion is probably too large.
May I say?
Yes.
Yes, Dr. Ikeda.
Yes, I totally agree. All of the discussion, and then I would like to see that the FDG PET again, because that the FDG PET show that hypometabolism, not necessarily the lateral tempora, but also the anterior to some extent to the major tempora. So that's convinced me that the resection of both the lateral and major could be very important at this moment.
That's a very good observation, Dr. Ikeda. So thank you very much for all the comments. So summarizing, this case was interesting, even though it was a lesional case, because we missed the lesion. We missed the temporal lesion on the first instance with MRI that the patient had come. He had come with a frontal encephalomalacia, a orbitofrontal encephalomalacia because of trauma. And when we repeated an MRI, we found a temporal lesion. And the video EEG very nicely, as shown by Manjari and also discussed with Christopher, localized the area to the temporal area. And then because of the dual nature of the pathology, we had to implant the patient. There was some discussion there whether we should implant or not. But yes, we did go ahead and implant, and that gave us a good decision to go ahead and remove the lesion plus, along with amygdalohypocampectomy. And we were able to do a lesion plus because it was on a non-dominant area. And plus there was some doubt that it was arising from the hippocampus. There was a suggestion from Dr. Kawai that one option is intraoperatively, you could always do an electrocardiography from the parahippocampal gyrus and then take a decision. So that's the summary of the case. Manjari has another small case. If she could wrap it up in 5 minutes, then we could go to the lecture. You're muted.
So I think we can do it at the end if there's time left. It's already an hour. It's just a routine ganglioglioma case because, I thought let's put a very simple and a little more complex case. So if there's time, we'll do it. Otherwise, we can always, skip it.
Okay. So thank you. Thank you very much for this participation. And now we go for today's lectures. So like all the cases, all the sessions of epilepsy surgery case by case, step by step. So we started with a case and then now we go in for didactic lectures. And before we go to the lectures, it's my duty to acknowledge our sponsors from IPCA who have given us this unrestricted educational grant to conduct these webinars. And we are really grateful to them. And so first I would like to, it's my pleasure to introduce Dr. Christopher Skidmore, who is an associate professor of neurology, vice chair for clinical affairs, associate neurology residency program director, Department of Neurology from Thomas Jefferson University. And he would give us a short lecture on preoperative assessment for temporal tumor and tumor-like conditions.
Everyone should be able to see my slides.
Yes, we can see your slides.
Okay. So these are my disclosures, nothing that's pertinent to this lecture today. So I think it's important to remember kind of what are our goals when we're kind of evaluating the patient prior to surgery. And, the first and foremost is, define the location and number of lesions, which as you can see in this last case that Dr. Tripathi presented, where you had 3 to 4 potential lesions, and you need to identify and take the time to go through your structural MRI imaging to make sure that you're not missing dual pathology, because dual pathology, especially in the temporal lobe, hippocampal plus something else, becomes very important because not all of the hippocampal sclerosis that you see is going to be glaringly obvious hippocampal sclerosis with atrophy and increased T2 signal. As you can see from the case that was just presented, the size of the hippocampus was relatively preserved and there was this subtle increased signal. And on pathologic examination for that case, there was hippocampal sclerosis. And so I do think it becomes important to remember that we need to identify all of the lesions in the brain. And then our goal is to, as neurologists, as epileptologists, is really to define as best we can with the non-invasive evaluation where the seizures are coming from. It's not often that, the seizures typically don't come from the tumor itself. It's usually from somewhere on the margin. And as Dr. Sharon had suggested, sometimes you need to look anterior and posterior. And unless the tumor is in a completely 100% resectable location with a good margin around it of at least a centimeter, it becomes important to try to define in which region, in which area around the tumor the seizures are coming from. And obviously, one of the most important things is to define, what is the risk of surgery? Is this going to damage eloquent cortex? And so that is the goal of the pre-surgical evaluation. And I think the way you operationalize this is to try to define 7 regions of the brain: the symptomatogenic zone, the irritative zone, the ictal onset zone, the functional deficit zone, the epileptogenic lesion, identify eloquent cortex, and then think about the epileptogenic zone. And so I'm going to just briefly kind of go over these. This is normally a much longer talk, but I think it's important to just briefly talk about each of the concepts. And so remember that the symptomatogenic zone is the region of the brain that's generating the seizure semiology. So in the case that we already discussed with that, left version in the sign of 4, all of this lateralizing, localizing to the right hemisphere, possible spread, as Dr. Ikeda suggested, into the frontal lobe with the bilateral asymmetric tonic posturing. So all of these semiologic clues are valuable independent of the rest of the evaluation. And I think for many people, we skip over the videos where we should be spending our time looking at the videos, talking to the patient, the caregivers, and looking at ictal videos. And these days, almost everyone has a video camera. And so in the past, we'd have to admit many patients to the inpatient video EEG monitoring unit. But now many of our patients come in with personal videos of events that were recorded at home that can give you a lot of useful information. Seizure semiology is merely the description of the clinical behavior. And what becomes important is to identify what the patient recalls from what a clinical observer saw. Are there auras? Are there very early signs that might suggest a localization? So auditory aura suggesting auditory cortex, visual aura suggesting visual cortex, so on and so forth. And then there's a whole host of lateralizing and localizing signs. And one of my good colleagues, Dr. Lodenkamper and Dr. Kodegal, who I had the pleasure of training with in Cleveland, wrote a very nice review article on this back in 2005, which I would encourage each of you to look at independently. Specifically with temporal lobe epilepsy, we're trying to understand, is the semiology a mesial pattern or is it a more lateral neocortical pattern? And so the typical things that we're looking for from a semiology perspective for mesial onset, the aura would be either a psychic aura or a viscerosensory aura or a fear aura, suggesting mesial temporal onset. There's often the presence of oral and manual automatisms, which this last patient did not have. And it typically is rarely secondarily generalizing. And if they do secondary generalize, it often occurs very late in the seizure, typically well after 60 seconds from seizure onset. But remember, this semiology can also be seen often in individuals with orbitofrontal lobe epilepsy, insula, and possibly in anterior cingulate. And so we need to kind of be aware of, while this is suggestive of mesial temporal, there are alternative hypotheses. Contrast that with the lateral temporal lobe, and now the typical semiology, we're looking again for that auditory aura if it's near Heschel's gyrus. We're looking for in the dominant hemisphere whether the individual could be having an aphasic seizure, and looking for those subtle signs of aphasia when we're examining the patient, both during the seizure as well as after the seizure. And often they have rapid secondary generalization. So typically in under 30 seconds or around 30 seconds or less, there's often this focal to bilateral tonic-clonic seizure, suggesting more of a neocortical onset. And again, just like for the mesial, there are alternative localizations. You could have frontal and parietal opercular cortex. You could have inferior parietal lobule, and cingulate and insula are also possible locations, for a lateral temporal semiology. If we then move on to EEG and start thinking about the irritative zone and the ictal onset zone. So the irritative zone is the region of the brain that generates the interictal epileptiform activity that we're recording. Most commonly, we do this with EEG, but you can also do that with magnetoencephalography, MEG. Theoretically, EEG fMRI and dense array scalp EEG would also be could be utilized. Whereas the ictal onset, it's kind of built into the name, is the region of the brain which is developing the first clinical ictal activity on the EEG. And again, we use the same modalities, but you can also, for ictal onset, you could do ictal SPECT or ictal PET, ictal SPECT being the most common, where you could do a syscom image of the interictal state versus the ictal state after an injection with a radionucleotide tracer to try to identify which region of the cortex is activating first at the beginning of a seizure. Moving on then, we want to think about, well, what is the functional deficit zone? So this is the region of the cortex that's not functioning normally in between seizures. So again, we most commonly will use neuropsychology as outlined in this last case, where there was a reduction in visual memory and visual constructive capabilities. But you also can do your neurological exam to look for weakness or plegia if the motor cortex was involved. We will often do FDG PET scans as well, looking at areas of hypometabolism in the interictal state to demonstrate regions of the cortex that are affected. And then you could potentially do interictal SPECT as well as EEG. And we also need to identify eloquent cortex, because obviously the goal of epilepsy surgery is to render somebody seizure free, but we don't want to injure them in the process. And so, there are multiple ways of identifying eloquent cortex. Most of those are more invasive, direct electrocortical stimulation, evoke potentials. You can do it non-invasively with MEG. But many centers now are doing functional MRI. Some centers are still doing intracarotid aminobarbital tests to look for memory and language lateralization. So there's numerous techniques that you can do to identify eloquent cortex to help provide you with an understanding of what eloquent cortex is in the region that we're interested in operating in. Obviously, this whole seminar series today is about temporal lobe tumors or tumor-like lesions. And so we can't ignore that epileptogenic lesion, and we need to kind of understand, again, the relationship of that lesion to all the other regions or zones that I just talked about. The most common technique here is going to be a good quality MRI with volume acquisition studies, both for T1 as well as FLAIR and T2 in both the axial and coronal plane, to make sure you don't miss a small lesion like the lesion that we just saw on that middle temporal gyrus. Certainly CTs of the brain are still used. And then PET imaging, for instance, flumazenal PET is a way to also potentially identify, regions that are of interest from an epileptogenic potential. So there's numerous modalities that could be contemplated. And then lastly is the epileptogenic zone. And this is a purely theoretical concept. It is the region of the brain which, when removed, results in cessation of the seizures. So there is no direct way to measure the epileptogenic zone. We can estimate the epileptogenic zone. We can hypothesize about the epileptogenic zone. But unfortunately, until you actually do the surgery, you don't know if you've successfully operated in the epileptogenic zone. And so if we kind of think about this and apply this and how we utilize this, so if the blue here is a lesion in the left anterior temporal lobe and the neocortex, we then get a routine EEG or the interictal EEG from video EEG monitoring. And we maybe get an fMRI and we identify Wernicke's area in the kind of inferior parietal region. We do an fMRI for memory and demonstrate that the patient has very strong memory, and we can do neuropsychology as well, suggesting that the verbal memory in this individual is robust. We then get that EEG demonstrating that there is a anterior to mid-temporal epileptiform spikes on EEG or MEG, for instance. We might then record a seizure in the epilepsy monitoring unit and demonstrate that the seizure onset appears to be more temporal pole, more anterior, not classically in the EEG pattern spreading to those mesial temporal structures based on the appearance of the ictal EEG. And then based on that, you may make a decision that, the epileptogenic lesion is in the area overlapping with the irritative zone and the ictal onset zone. That primary language area is well removed from this, but there's no great evidence on structural imaging or functional MRI or neuropsychological testing that there's damage to the mesial structures. And so you may make a decision to do a lesionectomy with a large border, sparing the mesial structures, the amygdala and the hippocampus. If you compare that with a different case, same thing here, the blue is epileptogenic lesion. Now you do fMRI for language, you still identify that Wernicke's region, but now based on neuropsychology and fMRI imaging, there is damage to the verbal memory. Now we can do the irritative zone, again, looking at that spike focus and demonstrate same anterior to mid region. And it's not uncommon that the spikes, the region of the epileptiform activity is much larger than the actual region that you need to absolutely operate in. And lo and behold, the pattern on EEG is more suggestive of a mesial temporal pattern for the ictal onset. And so now this epileptogenic zone requires a much larger, more of a typical standard temporal lobectomy maybe going back, 4 centimeters from the temporal tip, where you're going to take out the lesion, but you're also going to include almost all of the irritative zone and the mesial structures, because again, it's perceived that there is no risk to eloquent cortex. And so when you're just looking at a tumor on a scan, you can't decide how big or small your surgery needs to be. And you need to actually measure and work up the patient with these other regions or zones to help define what is going to be the ultimate resection that you're going to perform for the patient. And so the minimum workup, in my opinion, for any patient with a structural lesion, if you're thinking about doing a lesionectomy, is to do obviously a detailed history and physical exam. I think there is a value in those individuals that are having seizures to do video EEG monitoring to, again, understand what the brain is doing in between seizures as well as during an actual ictal event. You need to have a really nice volume acquisition MRI scan, ideally on 1.5 Tesla or higher, and then some way of measuring and assessing eloquent cortex. In our center, we will do fMRI and neuropsychological testing. Many centers will still do an intracarotid amibarbital study or a WADA test to identify language lateralization and to identify memory. We have moved away from that in our center over the last decade and almost exclusively use functional MRI to identify language cortex and memory function. And then bring this all back to a multidisciplinary conference where, the neurologist, the neurosurgeon, the radiologist, the neuropsychologist can really sit down and kind of discuss the case as a group to bring different viewpoints to the table, just like we did for the case that was already discussed today. And to think about, what are the hypotheses? Does all the data point to one spot, or is there more than one location potentially where the seizure can be coming from? If there are multiple locations, are they all in easily resectable locations that can be safely operated on? Or do we need to think about doing more non-invasive testing? Or do we need to proceed to invasive, video EEG monitoring? And so I will stop there and happy to answer any questions now or at the end of the session.
Thank you very much, Chris. I think we can take all the questions at the end of the session. So let me briefly introduce the next speaker. So it's my pleasure to introduce Professor Ashwini Sharan, who is a professor of neurological surgery and neurology, is a vice chair of clinical operation neurosurgery, program director for residency in neurological surgery division chief, and he's in charge of the epilepsy and neuromodulatory neurosurgery for Thomas Jefferson University. He has been earlier the president of CNS. He's an excellent surgeon. He's an innovator. He's got multiple patents. He's done some excellent groundbreaking work in neuromodulation. And him, along with his fellow, would be doing the presentation, Christopher Miller, on the surgical strategies for tumor and tumor-like conditions for temporal lobe epilepsy.
Great. Thank you for the introduction. And it's actually so nice to see everybody, even though we're virtually far away. The way Chris and I planned this presentation was, like Dr. Skidmore laid out, how you want to be thinking a framework for the ictal onset zone, the irritative zone, and the holy grail, which is the epileptogenic zone. Now, we know that more surgery statistically gives better outcomes, but the real elegant part is, can you figure out how much surgery to do? And so that is where the real discussion in lesional temporal lobe epilepsy comes, because we know that there is going to be more likely chance of cognitive or visual spatial or memory or subtype of deficits if you take out more temporal lobe tissue. So the way we prepared this discussion is to go through some cases that came through our unit and to show you how we sometimes did a more aggressive resection, sometimes we did a less aggressive resection, and sometimes we don't know if we did the right resection. So that is the way, and I look forward to the comments on how the panel looks at how we could have done better in some situations.
Well, like they were saying, my name's Christopher Miller. I'm the fellow for Dr. Sharan, and with him we'll be giving the presentation today. So starting out, there's no relevant disclosures to this discussion. This is our first case. It's a 24-year-old female who had initial seizure onset at 22 years of age. Her most relevant semiological feature was the chewing movements, Otherwise, there was not any specific lateralization or localization. With a complete surgical workup, there was noted to be a left temporal encephalocele. The PET scan also demonstrated decreased temporal uptake in that left temporal lobe in that region. She underwent neuropsych testing, which did not demonstrate any overt deficits. She was pretty much average across the board. Here is a coronal T2 demonstrating the imaging that we found. So this is a demonstration of encephalocele, which is the brain extruding out of the skull through an opening that is abnormal or shouldn't be there. So here you can see the bony edge on the MRI, and you can see this part of the cortex. And in this circumstance, there's actually obvious abnormal T2 signal in that cortical ribbon. As a note, oftentimes encephaloceles can be a lot more subtle and more difficult to find on MRI imaging than what was previously shown. So a thin cut CT scan can often be useful to locate defects in the skull base, as you can see here. So this patient underwent EMU stay, which demonstrated interictal and ictal findings. So here's the example of the interictal findings with T1F7 sharp waves. And in the ictal, there was noted to be 4 Hz theta activity in sort of the F7 T1 regions that then evolved into delta and spread throughout. So in sort of summary for this patient, the lateralization was noted to be predominantly left, localization temporal. Key features were oral automatisms as well as GI sensations, which were noted during the EMU stay. The encephalocele, which is on the left temporal lobe. Neuropsych demonstrated no major deficits, particularly relating to verbal memory and verbal functioning. Then on the ictal, there was sort of theta and delta activity localized to the left temporal lobe. So at this point, it sort of opens it up to discussion as far as what, if anything, is needed more for this patient. Should an implant or invasive monitoring be done? As far as if you wanted to proceed to a surgical plan, should it be a lesionectomy? Should it be a lesionectomy plus a margin around that lesion? Should there be a full lateral temporal lobectomy with sparing of mesial structures? And if so, which structures should be spared? And otherwise, if you wanted to do a full resection, would that be warranted in this case?
Yeah, so this is where in this case, we present this as a general framework for everybody to say how does the decision-making process actually go. So if we did a lesionectomy with a small margin, since this is anterior temporal pole, that's a fairly safe operation. You can actually repair the floor of the middle fossa. Now, that means that the rest of the mesial temporal lobe is not involved. This patient has, some suggestion of a semiology that I forget if it was amygdala. So there is some involvement there. The neuropsych tends not to show that this person has any significant memory deficits in a dominant temporal lobe case. And so that also tends to imply that the mesial temporal lobe structures may not be involved. So without invasive monitoring, you have some ideas that there could be amygdala involvement, but not hippocampus involvement. And if the concern were to try to differentiate that, then the person would need an implant if you wanted to try to do the perfect operation right from the beginning onset. Now, knowing that there's certain constraints and sometimes you have to make good clinical judgment, in this person, you can consider a lesionectomy plus 1 centimeter surrounding it. If you look at the MRI, it's in a fairly safe, non-eloquent region of the brain. So those are some of the ways to go about the decision-making. I think I would go back to the next slide, Chris. So we just wanted to present that to, and of course, if you spare the mesial structures, there's less likely to be cognitive deficits. I don't know if anybody else on the panel wants to jump in on how to approach that case. Perhaps, Sarath?
I would be more in favor of doing a lesionectomy with a margin excision, because given the data that I'm not too convinced whether the mesial structures are involved or not. I don't know how others. Dr. Kawai?
Yes, first of all, the many so far reported cases, the lesionectomy or lesionectomy plus kind of marginal resection is the sufficient for this temporal pole encephalocele. And I have experience of 3 cases, and we reported 2 of them. And one of them was very interesting. It was kind of shame, but we didn't notice the encephaloceles, and we thought that case was non-lesional TLE, and we put the subdural electrode. And we did not detect the seizure, but only, implantation of the subdural the electrode abolish the seizure thereafter, many years. Okay, so generally speaking, and in this case, the seizure duration is only 2 years. And usually we don't have to think about the secondary epileptogenesis. So I think regenectomy or regenectomy plus margin resection is enough. And actually, last month we did the endonasal the approach, the endonasal endonasal approach to the encephalocele, and we recorded intraoperatively, and we didn't detect the spike from encephalocele itself, but we proceed kind of a needle electrode deeper, and then we could record the spike. So I think that regenectomy plus margin, I prefer myself a regenectomy plus margin than regenectomy alone.
And I'll add, in the day before we switched to mainly stereo and subdural, I think I've had at least 2 cases where we had decreased seizures. And when we went back, and there was a little irritative zone around the subdural, and it was where the encephalocele is. But I think we put this case also because encephaloceles might be a common finding in patients. They're not always epileptogenic, but they can be epileptogenic. So take it over, Chris.
Okay, so in our case, we generally agree. I think certainly we were not thinking about going after mesial structures on this patient. We ultimately elected for a lesionectomy demonstrated here. So here's the preoperative scan where you can see the encephalocele, and then the post-op scan where you see removal of the encephalocele cortex, as well as the repair of the skull base and redefinition of the skull base. Unfortunately, this patient quickly recurred. 2 months later, ended up having recurrence of seizures, including a new seizure type, which was a focal aware. They slightly new semiology with some spine chilling sensation, otherwise continuing with the automatogen, and now was noted to have a right head versive turn. Underwent repeat surgical workup, including fMRI, which was to localize the left language. The MRI was now was remarkable for the postoperative gliosis. Her overall neuropsych remained mostly unchanged. There was some increase in depression, as well as mild decrease in naming, but still performing fairly well within all cognitive tasks. So here's the reshowing of the MRI, which demonstrates on T2, increased T2 signals throughout the temporal lobe. Again, here demonstrating the axial scans, the T2 signal in the anterior left temporal lobe. So the patient underwent EMU stay, which again, we were able to capture a couple of her seizure types. And interestingly enough, the EEG showed increased rate of activity within the onset zone. So here's demonstrated the interictal sharp waves. And then this is the sort of increased 10 to 14 hertz activity, which then ultimately evolves into delta and again spreads. So again, we have another summary at this point. So again, leaning stronger on the left side, again, still localizing to the temporal lobe. Overall, the notes or the semiology is a little more pronounced. We had captured a figure 4 and some head version. Otherwise, there was continued encephalomalacia. The fMRI was demonstrating left language. The temporal lobe was now demonstrating sort of a 10 to 12 hertz onset rather than the slow with theta onset that we saw in the prior EEG. So again, sort of similar discussion at this point. However, with the rear sort of prior resection of the lesion, one could either consider that we need to go back and consider the margin, or whether or not the new encephalomalacia is now the new sort of lesion that needs to be resected. And then the lateral temporal lobectomy, just doing a larger surgery to ensure more active or more tissue is removed to hopefully capture the epileptogenic zone and be more sure of that, or whether at this point, since it's already a repeat surgery, just to go completely after the mesial structures. For our case, we decided that since the verbal cognitive scores with the neuropsychological examination demonstrated that this patient still had good verbal memory, and we knew the memory or the verbal tasks were being done on the left side as the dominant side. We elected to continue just with the lateral temporal lobectomy. So we ultimately defined our resection based on respect for the Brokaw's area, the Wernicke's area, where we sort of took a less of a distance back from the pole superiorly, and then as we progressed inferiorly, took more and more cortex. That is demonstrated here. So you can see the much larger resection than previously, but the mesial structures being left intact. Here we see encephaloceles. This is an intraoperative photo demonstrating encephaloceles. As I noted, it's sort of just a opening in the skull base, and you can see the dura occasionally can wrap and go clear into these encephaloceles, which will maintain the CSF and prevent any leaks. However, generally speaking, when you're doing any of these, you have to be very aware that the dura is likely to be damaged or weakened such that it will likely need some sort of repair, and sometimes needs an extensive repair just to make sure the patient doesn't experience CSF leaks once you remove the brain that was previously in the encephalocele. This is sort of what a skull-base repair might look like. For this patient, they just required a dural analog. This is a bovine pericardium sort of dural replacement. So after that resection, the patient's doing very well. They're Ingle 1C at 3 years. So just a brief mention of a relatively recent paper that came out just this year, where they had done a systematic review of encephaloceles. And they noted 267 that were papers that had patients that had been published with encephaloceles associated with epilepsy. The vast majority of them were in the temporal lobe. They had a variety of surgical interventions, including majority lesionectomy versus complete lobectomy. Here you can see the seizure freedom results. Generally speaking, these patients do well regardless of the therapy. The lesionectomy only demonstrated a very good response, 87%. Partial lobectomy, a little bit less so. The complete lobectomy was reported in this paper as 44%. However, I would like to note that they included in that calculation 34 patients that did not have a specified result. If you're to remove these 34 patients that did not have specified results, then the number jumps up to 88% if you do a complete lobectomy, which is basically similar to what the lesionectomy only case would be. They did also note in the 58 patients that had not undergone any surgical intervention, 17% of those were seizure-free on medications alone.
So before we jump,
moving on to the next case.
A big part that I want to add to this whole point about encephalocele is, I think that as we start looking for encephaloceles, I think we're realizing that we're seeing more than we're acutely or keenly looking at the MRI. And in this case, we also present interestingly, look, as a panel of experts, we all thought that a lesionectomy plus a little margin was the right operation, but the epileptogenic zone was likely larger. And I don't know if that was because there were more encephaloceles that we didn't give credit to. Inevitably, I think our general impression, like everyone's, was right, spare the mesial structures, because that doesn't have any, all our measurements on neuropsych were showing that was worth sparing. If we did an implant, would we have come to this conclusion sooner? That would also have costed 2 operations. The other important thing in this case to note is after we did the lesion plus, the semiology changed or evolved. And so it actually started having versive, the sinophore, the versive head movements. So we did change the way the epileptogenic zone was behaving because a part of it was removed. So important to consider all these things when you're doing surgery.
Yeah, and I would add that the ictal pattern the second time around with that essentially beta rhythm, fast alpha beta rhythm, is again not typical for mesial temporal onset epilepsy, right? So in addition to the fact that there was, obviously an eloquent cortex and the hippocampus on the left was still functioning from a day-to-day perspective with verbal memory, the ictal pattern also was not typical for mesial temporal. So I think it was more suggestive of doing a sparing procedure, which you did.
So proceeding with the next case, this is a 20-year-old female who's had seizures for 7 years at the time that we met her. She had primarily a focal impaired awareness type with oral automatisms. She didn't have any particular risk factors on imaging. She was noticed to have a cavernous malformation and left language dominance on fMRI. Overall, her neuropsych was average, though she did have low average verbal memories and perhaps more involvement of the dominant structures. Here is a demonstration of the MRI. So this is a coronal T2 with, you can see the cavernoma sort of on the lateral inferior temporal gyrus here. So demonstrating some other images. If you look on the right, this T2 now just demonstrating the hippocampus bilaterally, sort of normal size, shape, rotation, as well as dentation. Now the axial flare images demonstrating equal flare signal bilaterally. You can see yellow demarcates where the cavernoma would be found. The patient underwent EMU stay, which demonstrated interictal and ictal findings. Again, T1F7 sharp waves in wakefulness and sleep. And then the patient had 3 to 4 hertz activity that sort of evolved into 5 to 6 hertz and then spread, demonstrated here. So again, quick summary, lateralization is generally left, again, localization generally temporal, semiologic findings of oral automatisms, MRI finding of the lesional cavernoma, left language dominance, as well as but a slight decrease in verbal memory, and then the delta to theta activity. So again, similar questions. Given that we have an obvious lesion, does this patient warrant an implant prior to any surgical intervention based on any of the other findings? If you were to proceed with a surgical plan, would it be lesionectomy plus margin, or lateral temporal lobectomy, and sparing of what, if any? So I'll kind of open this up again to discussion. Dr. Kawai, do you have any comments?
I do the lesionectomy plus margin, and I usually do not do the lateral temporal lobectomy. Even if you leave the hippocampus, if you kind of resect the lateral part of the hippocampus, which forms gyrus, then you will lose, the hippocampal connection, and that will cause the memory, verbal memory decline after surgery. So, in the dominant side, on the dominant side, I'll do the lesionectomy plus margin only.
Yeah, I agree with this. I too agree with this because it's on the dominant side. Plus, I don't see so much of changes around the cavernoma. The cavernoma seems to be pretty focal. So just the excision of the cavernoma with adequate excision of hemosiderin ring should do the job. And in such cases, I really don't know what's the utility of electrocorticography, because we don't see any changes in electrocorticography.
No, that's a great point, Sarath. We would do these cases with electrocorticography, and I think it makes us feel a little bit better that we're doing something to determine the extent of the margin. But that is also our customary practice at Jefferson, to do electrocorticography during resection.
I think all of us do electrocorticography, but it's only helpful for pathologies like cortical dysplasias. In cavernomas, usually we find that the electrocorticography is normal. I don't know if you found anything abnormal here.
Just as an aside, Sarat, as you know, we have a deep love of EEG where I'm from, and we routinely do a corticography for all lesions, and for that matter, for mesial temporal sclerosis. And in mesial temporal sclerosis, we tailor the resection, not because of the mesial temporal sclerosis, but because of the very common anterior temporal pole dysplasia associated with it. And I've got to say, the more electrocorticography you do, the more experience you have, and therefore the greater confidence you have in patterns that may be of relevance. And certainly when it comes to the cavernoma, peri-lesional cavernoma, it's very common to have electrocorticography showing spikes. Our experience differs from yours in the fact that the electrocorticography in around a lesion, particularly a cavernoma, commonly shows interictal spiking during the surgery.
So, I mean, it's interesting with this case, the semiology is more suggestive of mesial temporal. The ictal EEG pattern reaching theta frequency, we didn't talk about within 30 seconds, but I assume it was early on, also classically seen more with mesial temporal involvement. So I think the mesial temporal lobe is certainly at least involved in a region of spread from the region of the cavernoma. And on the T1 weighted imaging, while the volume of the hippocampus was normal, it did look a little bit smoother. There was less indentations in the head of the hippocampus. So again, you wonder, could there be some subtle involvement of the hippocampus, even though this is relatively early on? It's only about 7 years from onset of the epilepsy. So I'm okay with doing a lesionectomy. I just think I would wonder, are we going to be coming back in a couple months and trying to address this dominant hippocampus and amygdala region?
Just on that point, Chris, routinely when we're doing electrocorticographies for such a lesion, we also do electrocorticography over the mesial temporal structures. Now, we don't use that to guide surgery because prior to the person going to surgery, the goal is lesion and peri-lesional resection. But it is notable that if you see striking mesial temporal spiking that doesn't remit after the lesionectomy, these are the kind of patients, a bit like you've said, who, 6 months later you're back again. But then that's okay because we are protecting the patient from surgery that can cause them harm, and a second stage procedure is justified in this kind of lesional situation.
Yeah, I agree completely.
Okay. Well, we ultimately decided to proceed with a lesionectomy in this case. As a surgical nuance, the incision that we designed for this one was designed such that if we needed to come back and do a more extensive resection of the mesial or anterior temporal structure, we would be able to do that, sort of the posterior aspect of the reverse question mark that would usually continue all the way around, as seen in our prior surgical photo. This is the example of the lesionectomy. We did a lesionectomy with a slight margin, not much more, but remained with the mesial structures completely intact. This patient's doing very well. It appeared that was all they're needed. They're now 4 years post-op with an angle 1A. So now to show a little bit of differentiation, this is another cavernoma case, but a little bit different details. So this is a 48-year-old male who's had intractable seizures since 40 years old. They have 3 different seizure types. The main notable part of the semiology is aura with fear. The patient does have a history of head trauma, including boxing. Their imaging does show a lesion and other cavernous malformation. However, this one is located at the hippocampal amygdala junction. The patient underwent fMRI, which demonstrated left language function, but interestingly, it was also left biased visuosemantic memory. It was noted bilaterally, but noted to be stronger on the left side. Neuropsych was not done for this patient. Here's a demonstration of the, again, coronal T2 demonstrating the lesion here, the cavernoma right here at the amygdala hippocampal junction, which can be seen in the axial flare image as well. This patient underwent EMU stay, who at that time was noted to sort of have smaller versions of the seizures they typically had. There were intraictal as well as ictal findings. Here's a demonstration of the T2 F8 sharp waves. Again, now demonstration of an actual seizure where there was noted to be rhythmic theta that evolved into delta, demonstrated here again predominantly on the right side. So looking at the summary of that, again, lateralization is pretty much all on the right side, with mostly in temporal lobe. Semiology-wise, the aura demonstrated fear. There was a cavernoma noted on imaging. Like I said, left language, but bilateral visuosemantic memory, and then theta to delta activity as far as the characteristic of the EEG. So I think open this one up again for discussion. Same sort of discussion points. We have a lesion that is now more intimately associated with the mesial structures. Otherwise, relatively similar features, though not as indicative semiology at this point. So again, as far as what people might try for this, I'll start with Dr. Sharath.
Did you say me, Chris, or did you say Sarath? I missed it.
Oh, sorry. Either one. Dr. Sharath, go ahead.
Yeah, so I think this case is a little bit more clear forward. I mean, we put this case together because it's a cortical cavernoma, but it's at the hippocampal amygdala junction, and the semiology and the seizure generator pattern on the ictal EEG is also suggesting that the hippocampus is involved as the theta builds up into. It was a nice 5 to 6 hertz delta. I think that you showed that on the EEG as well. So this person, I think, really should have a cavernoma plus a formal temporal lobectomy where you're taking out the mesial structures and the hippocampus for sure.
I guess that's correct. The neurologist won't leave you if you leave the hippocampus behind.
So my question is, in such cases, is there any role of invasive EEG? Could you put some SEG electrodes maybe in the anterior and the posterior part, and then think of only partial hippocampal resection?
Yeah, I mean, I think, I don't know if Dr. Kawai has, because I know the literature comes out of Japan. I think the other things that I've seen done innovatively in the world is when people try to do hippocampal transections. And so I think the point you're bringing up is the whole hippocampus involved, and is there any advantage sparing? Unfortunately, we don't have really much experience with that.
Yes, and Ashwini, as you know, there are different beliefs in this. George Ogerman, of course, was a great advocate for preserving segments of posterior hippocampus, and one of our surgeons trained with George, and so we'd be doing that kind of approach. But the data on removing amygdala and anterior hippocampus and removing a bit of tail and preserving a bit of tail is unclear about whether that's actually going to produce an advantage for the patient. And so it's controversial.
Can I make a comment about that? I think if you remove for example, the anterior part of hippocampus or posterior part of hippocampus with fimbria, then you will kind of disconnect the neural circuit, and that will cause the memory disturbance. But if you leave the fimbria and retinal connection intact, and cut the hippocampus perpendicular to that, is a hippocampal transection. And on the dominant side, like this case, I remove the cavernoma and then do the hippocampal transection. But in this case, this is the right side. I will remove the hippocampus.
Well, thank you. We sort of agree with the panel here. We ultimately went for a complete anterior temporal lobectomy, including the mesial structures, which is demonstrated here. This patient is doing well. They've had one significant seizure since that surgery, which was related to sleep deprivation. Otherwise, only seizures have been related to missed medications, and they're now 2 years out. So just in summary of kind of what we looked at today, the temporal neocortical cases are often lesional, which there can be a number of different lesions that contribute to this. And the pre-surgical workup, as you've seen from the discussion today, it's important to gather a lot of information, including neuropsych, fMRI, as well as EEG data to help make decisions about how much resection to do, the extent of resection, and whether to involve mesial structures. I'd be happy to take any questions at this point.
There's a question from the Cairo, Egypt.
So I can read the question out. So Dr. Kishk from Cairo, Egypt asks, cases of encephalocele, should we perform a lumbar puncture to assess the opening pressure before operation? Should we close the defect with lesionectomy to avoid recurrence? I don't exactly understand what is the question.
No, I think what he's referring to is there's some data that suggests that patients who have encephaloceles have hydrocephalus. And so I think the question is, once you do a craniotomy, I doubt you can, is there a subtle hydrocephalus, you would miss it. And so I think maybe he's implying, that should we be thinking about hydrocephalus more often, perhaps?
Okay.
I did the temporal pole disconnection. And so not a removal of temporal pole. So just disconnect the temporal pole with the encephalocele. So I left the temporal pole covering the encephalocele to avoid the closure of the defect. And that is another surgical option, I guess.
Yeah, I think in general, when you're removing these lesions, there's obviously defects in the skull base here. So I think some strategy to ensure there's no continued leakage or other issue with the holes in the skull base, it warrants some sort of repair, or at least strategy, as Dr. Kawai noted.
So there is one more question from the same delegate. He asks that in the first case of neocortical cavernoma, if you had electrocorticography showing some changes from hippocampus, would you prefer to remove the hippocampus?
Well, since I was the advocate of electrocorticography, I should describe our own experience. In essence, the lateral temporal neocortex and mesial temporal structures are next door neighbours. And so pre-resectionally, it would be very common for the electrical field of the interictal spikes to involve the entire of that region. And so if pre-resectionally we were seeing mesial temporal spikes, we would remove the lesion and an appropriate margin, as Sarat and Ashwini have said, and then post-resection look at electrocorticography. Post-resection, electrocorticography has major issues because it's very common you get injury potentials and you have peri-resectional burst suppression. And so you can see a field of the injury potentials that bear no resemblance to the pre-resectional spikes, and they need to be ignored. Back to what I mentioned earlier, if the plan for resection is the removal of the lateral neocortical resection and see how the patient goes, we would not proceed to removing the mesial temporal structures in that person for the various reasons that I've outlined, including the limitations. The other thing is that there are spikes and other spikes, and once you've removed brain, around the resection, you're going to see peri-resectional burst suppression type spikes, which are not residual spikes. They're completely different in morphology and characteristics to the pre-resection spikes. And this is a very important point.
Thank you. Thank you, Dr. Dunn. That is really useful. So there are a couple of more.
May I say one?
Yes,
one
Dr.
thing?
Kedar.
Yes, I essentially agree that John. And speaking of the intraoperative spike or the easy seizure pattern, which is the very the worrisome, but at the same time, if we convince that this is so-called that the red spike seen as the quite repetitive spike in case of focal cortical dysplasia, we may decide to resect it. But otherwise, the easy seizure pattern for a very short period, or some brief this ictal pattern-like activity may be produced by some sort of the effects of the decreased medication or some surgical the situation. So therefore, one event of these kind of things may not bring us to that the resection of this area. So that's what I feel at this moment. Thank you.
Thank you. Thank you very much. So there is another question which I would like to put across to the guest faculty. So now most of the cases of tumor-like conditions causing epilepsy, we do have an inherent resistance to do invasive EEG because we are seeing the lesion on MRI. So would you suggest of any indications where you think an invasive EEG would be required in such cases? Ashwini or Chris?
I think one case that may come up, we spoke about 2 cavernoma cases, and we were fortunate in those 2 cases to have solitary cavernoma lesions, but it's not unusual for a patient who has familial cavernoma disease to have multiple lesions, at which point, they may have multiple in the temporal lobe or in other parts of the brain entirely that may warrant a, more better spatial resolution as far as the EEG workup. So I think multi-lesional cases, sort of like the first case that we saw from Dr. Chapathi would be a good example of something where you have multiple lesions and would want to consider doing SEEG. But ultimately, it sort of boils down to your confidence with the non-invasive workup.
And I agree. And there are other cases, like when we showed the encephalocele, we didn't implant that person, and that person ended up having a larger region. And perhaps if we had implanted that person, we would have done one operation with the full, tailored resection. So these are very difficult questions to put a blanket. And I think it's just that I think that everybody who's on visiting today's event, you really have to have this very systematic framework on how to think through the problem. And then sometimes if you're not right, then have another hypothesis on what the whole epileptogenic zone is, and then consider an implant at that situation if the lesionectomy approach is not working.
The good news, and as Chris has mentioned, and as you've described so well, is that in the majority of patients with lesional epilepsy, they've got one lesion, their semiology, their surface EEG, and the lesion all add up. And in an area of our region in particular, where resourcing and is limited and invasive monitoring is outside of the horizon of many countries, let alone individuals, well-evaluated clinical patients with appropriate imaging and surface monitoring should allow, in the majority of patients, to proceed to surgery without invasive monitoring. And that's good news.
And I agree with that. I think the biggest mistake is to not operate on these people because you say that you don't have the ability to do intracranial EEG, because if it's a lesion and the majority of the non-invasive evaluation is pointing to that one spot, it's in a location that can be safely removed with a reasonable margin. I think one of the most important things when we talk to the surgeons in our center that just do tumors, we have to kind of tell them, no, it's the tumor plus the epilepsy. So you have to think about both combined, and that you really need that margin of resection. And as long as that the lesion with a margin can be done, oftentimes that's the lowest morbidity procedure to try first. And then that fails, then move on to maybe some of these other, more invasive techniques as needed.
So I could summarize by saying that in most cases, like Dr. Dunn said, if there's a lesion and the semiology, the history, the semiology, video EEG and the imaging is concordant to that particular lesion, then you don't need any further investigations. However, when there's a mismatch and a non-concordance of the semiology, so you have a temporal lesion but the semiology is completely frontal or something else, then it should raise a red flag to do further investigations, maximize the non-invasive investigations. Also, if there are multiple lesions, again, we would need to have a clearer, concept of which of those lesions is responsible for the ictal onsets, majority of the seizures. So I think many just started centers where trained neurologists, trained neurosurgeons are available should be able to do a simple DNET or a ganglioglioma with concordance of the video EEG ictal onsets to the MRI. Is that correct, Dr. Dunn and Dr. Chris and Dr. Ikeda?
I would like to add two matters, if it is agreeable for all of you. I would like to consider, first one is that the etiology or the characteristic of the lesion. If the MRI can suggestive of the lesion is the clearly focal cortical dysplasia, it may be invisible with regards to that extent of the margin. So that is the very important warning, the sign. The second thing is that the possible dural pathology. If the lesion is that's the temporal and more or less close to that the hippocampus or still in the temporal lobe, the possibility of dural pathology could be considered. So I totally agree with the John and then the Chris and also the Manjari, but I would like to add it to the warning, the situation. Thank you.
Thank you for that excellent discussion. So the final question is that in today's cases, we have seen the case presented by Manjari, where we had a lateral neocortical lesion, but we ended up removing the amygdala and the hippocampus because we felt that there was an involvement of amygdala and hippocampus as shown by SCG. And then in the case presented by Ashwini, where the cavernoma was mesial, and once again, they had done a standard temporal lobectomy with mesial structure resection. So overall, what do you think are the guidelines where you would need to do an amygdala and hippocampal resection? And this is general guidelines for people watching this from so many countries. Because again, this is a big issue which comes up. You see a lesion, should you remove the mesial structures or not? So perhaps we can start with Ashwini and then go to Dr. Kawai and then go to the neurologists.
Yeah, the general approach that I think we should advise people is in the non-dominant, in the case where there is clear non-dominant versus dominant apparent, then if there is any suggestion of mesial outflow based on ictal-EEG, semiology, or MR imaging, then you should consider doing a mesial resection in terms and in addition to the lesionectomy on a non-dominant hemisphere. In the dominant hemisphere, I really do think that the more conservative approach is better because the cognitive deficits can occur. Now, having said that, in an environment where they're resource constrained, there is good data that says that when you remove the right epileptogenic structures, so that if there is enough tests to suggest that the mesial is involved, then that's actually a judgment call that has to be made. Because you're likely not, if the mesial structures are involved, you're likely not causing a work deficit. So there's two aspects of this that should be considered, is also the patient's social and professional situation. We actually do obsess about memory deficits, which I think is appropriate, but every memory deficit does not result into a work-related employment deficit either. So I just want to add that to the discussion.
Dr. Kawai, you want to add something to this?
No, there is nothing to add. Dr. Sharan's comment is the perfect as a guideline. I quite agree.
So, any other comments from other faculty? So I think there are none. So now I will request Dr. Kawai.
I'd like to say that wherever we are in the dominant, situation, dominant hemisphere, dominant temporal lobe, and there's a lesion which is very close to the hippocampus, often on counseling of the patients, we do tell them, as well as a caregiver, that we are just removing the lesion because there is your left hippocampus, which subserves the verbal memory, and you may have deficits later. And we do have to counsel them that if there is a recurrence, then we may have to go in again. So I think that preemptive counseling is very important when we are leaving things behind. Yeah.
So thank you, Manjari, for that comment. So now I will request my co-convener, Dr. Kawai, to summarize and close this webinar.
Okay, so tonight, this time again, we could learn a lot of things, and we could make a lot of deep discussion about the temporal lobe with temporal lobe epilepsy with the neocortical lesion and medial temporal lesions, and so that. We really appreciate the attendance of doctors from Thomas Jefferson University and their didactic lectures and variable cases. And also, I'd like to thank again to Dr. Professor Sarat Chandra and the Manjari Pariyati for preparation of cases and organization of the webinar. So this is a kind of closing remark, and pretty solid as the final comment.
So thank you so much, Professor Kawai. My gratitude to everybody, starting with Professor John Dunn, Chair of AOILE, and Professor Ikeda, past chair of AOILE, for showing us the leadership and also allowing us to do this great series of webinars. We would be coming back next time for MRI negative pathologists in temporal lobe epilepsy, and we all hope that our viewers will join in again and continue to make this webinar series very popular. And a word of thanks to the entire team from Thomas Jefferson, Professor Christopher Skidmore from neurology, Professor Ashwini Sharan, and Dr. Chris Miller for doing a great job and presenting the great lectures and showing us very relevant cases. I think it was a fantastic webinar. Thank you very much. Goodbye and stay safe.